All right, I think we're going to get things kicked off. I am Dr. Jhanelle Gray, the chair for the Department of Thoracic Oncology here at Moffitt Cancer Center, and welcome to everyone. Thanks to those of us who are joining us via this webinar online. We have an exciting evening planned and a lot of information on this webinar. I am confident that you will find value, I think, in what my colleagues have to share tonight. And before we begin, I do have to do some housekeeping. So we'll go to the next slide, please. Apologies, I do have to read this. The content is not intended to be medical advice, and the viewers should consult their physician should they have any questions. The viewers should not rely on information contained in this presentation, webinar for immediate or urgent medical needs. Additionally, if you think you have a medical emergency, please call your physician, go to the nearest emergency room, or call 911 immediately. Never disregard medical advice, especially from a professional, or delay seeking care because of information contained in this presentation or webinar. So again, we are so pleased to have you with us tonight. We share some of our exciting breakthroughs this evening, starting with our first speaker. And before I introduce her, I would like to remind you that you are here to really engage with our experts. You have the opportunity to ask questions and get them answered. We invite you to share your questions. You'll see on your screen in the Q&A box located there. It should be at the bottom. And now on to our presentations. So I am very pleased to introduce Dr. Bruna Pellini. She is an expert thoracic medical oncologist. She's really a leader in the field of liquid biopsies, circulating tumor DNA, and targeted therapies. And she'll be speaking to us about liquid biopsies in thoracic oncology. So Dr. Bruna Pellini, please take it away.
Thank you, Dr. Gray, for the introduction. So as Dr. Gray said, my interest in research is very focused on liquid biopsies. So if some of my patients are watching this, I probably explain to you what this is. But for those who haven't seen me in clinic, what is a liquid biopsy? So basically, this concept came to life like a few years ago because for many, many years, we know we are able to see material from the cancer cells in the bloodstream. But we didn't have the technology to analyze this material, this DNA, this RNA, there's like the building blocks of the cancer cells. But nowadays, and more recently, it's in the last 10 years, the technology's got so much better. So we are able to detect this circulating tumor DNA or ctDNA that we talk about in the bloodstream. So basically, imagine this. You have all these cancer cells, and they're constantly growing and shedding this material in the bloodstream. Although we can detect this, it depends on the size of the cancer. It depends on how many cancer spots a patient has for us to have higher levels of this material. Also, is a little bit of a needle in a haystack situation when the cancer is very small, because you have DNA from your normal cells being shed into the bloodstream. So you're really trying to detect that small portion that is coming from the cancer cells. So if a patient has a disease that is advanced, is metastatic, maybe 10% of this whole cell-free DNA that the blood has is composed of tumor-derived DNA or ctDNA. But now if a patient has early stage disease, so just a small tumor, stage 1 disease, maybe less than 1% of this whole amount of DNA in the bloodstream is actually coming from the cancer cells. And this is what this picture is trying to show. It's from one of my early publications showing how this DNA from cancer cells gets there. So active secretion, like I explained, and also because the cells, they die, they also shed material, so the necrosis and the apoptosis. So in the next slide, I will show to you, if you can advance, the applications in thoracic oncology. So what you guys will see in clinic nowadays is what we call molecular profiling. Molecular profiling means that in that DNA, we're gonna look at the building blocks, the genes of this cancer, and see if any of those genes are mutated. Why is this so important? because it changes how we treat the cancer. And this is currently the only approved use nowadays that does really change what we do as clinicians. So for instance, if I find an EGFR mutation that is showing this figure, then I will treat this patient with a targeted therapy against that mutation. But unfortunately, there are many situations where patients have mutations, but we cannot target them. But still, this is a really good tool, and we use that on a daily basis. Treatment response monitoring is something that is emerging now, and I will share some exciting publication that I had this year on that topic. But basically, the concept is, what if we can assess whether a treatment is working before we see the disease growing on the CAT scan? And if we do that, can we change a patient's treatment earlier on and see, will that improve this patient's outcome? Will this patient live longer? Will this patient be able to have better outcomes? So this is an active area of research that we are doing here at Moffitt and also with our colleagues outside Moffitt. Another super exciting area is minimal residual disease detection. There are commercial assays for the uses of minimal residual disease detection and response monitoring, but it doesn't change what we do in the clinical practice. That's why we don't order. But the MRD, or minimal residual disease detection, happens when, let's say, a patient undergoes surgery. And nowadays, we have an option either to give additional treatment if we gave some kind of IV treatment before surgery, or not give this additional treatment, because we have different ways of treating early stage lung cancer given the new approvals. So the idea is, well, what if I could do a blood test and I could risk stratify my patients, meaning I could know who has a higher risk? The problem is the assays are not perfect, and the technology, in my opinion, is not there yet for us to make these decisions, because there are many times that the test may be negative, but is what we call a false negative. So the patient does have minimal residual disease, but at the time of the blood collection, the material wasn't there. So then it was negative. So I would be treating my patient as a low risk, when actually this patient could still have a high risk for the disease to come back. But as the technologies evolve, it's really important for us to do studies where we collect these blood samples in the setting to try to see if we can personalize treatment. And the last area of research with liquid biopsies is early cancer detection. So the idea that with a blood test, you would be able to tell if somebody has cancer. So nowadays we have lung cancer screening with CT scans, like low-dose CT scans. I know my colleague, Dr. Freyaldenhoven, will talk about it, but there are very few patients that do that. But what if we could do that with a blood test? But like I said, the applications depicted in B, C, and D are research use only. They're not being done in clinical practice. But I do want to share some exciting findings from a study that I conducted. So in the next slide, the whole idea was, well, we know that most patients don't have these mutations that I can use pills for that will target the alteration. Most patients are getting some kind of IV treatment with chemo immunotherapy. So what if in the beginning of the treatment, what we call the induction period, where we're still using like 2 chemo drugs and 1 immunotherapy, we could collect a blood sample and we could see who has a positive ctDNA, that DNA that is coming from the cancer cells, versus the ones that don't. So here you can see that these patients in this study that I conducted, the red line or orange line, depending how your screen is showing that patients that had a positive ctDNA after 3 cycles of chemo and immunotherapy had lower time free of cancer growth, or progression-free survival. That's what that means, time free of disease growth. And these patients that also had this positive ctDNA had a shorter survival. So what does that tell us? That this is prognostic biomarker, that this is a biomarker that tells me the risk of my patients. So if somebody still has DNA from the cancer cells detected after a few cycles of chemoimmunotherapy, these were patients with stage 4 disease and curable cancer, those patients have a higher risk for the disease to grow. So those are the patients that maybe I need to think about more aggressive treatment strategies to help them live longer and stay free of disease growth for a longer time. So this information is helping me, together with Dr. Gray, through a cooperative group, to design a clinical trial using this technology to see if we can personalize treatment for these patients that have a higher risk and hopefully improve their outcomes. And this wouldn't have been possible if we hadn't conducted this study that led to this idea. So in the next slide, I do want to share some of the ongoing research here. I have two protocols open here at Moffitt. One is to collect blood samples for patients that have stage 2 or 3 disease that are undergoing chemo and radiation followed by immunotherapy. Because the same idea that I have in the space of stage 4 disease, we are trying to investigate in the earlier stages. So can I detect ctDNA in these patients? I know I can, but now the question is, when is the best time to do the blood test? Is it a week after chemoradiation, 2 weeks, 3 weeks, 4 weeks? So this, nobody knows. And this is something that I'm trying to look by doing this study. So I have had several patients volunteer and donate blood samples, which is basically what I'm asking of the participants, because then later on, I'm gonna analyze these blood samples that are being collected at different time points to hopefully create an idea for the optimal time point and then design a trial that can potentially change how we treat these patients. A second study that is ongoing is for patients that have a KRAS G12C mutation. This is one of my areas of research, KRAS mutant lung cancer. So patients that have stage 4 disease that are undergoing treatment with some of these pills that target this mutation, I'm also asking them to participate and donate blood before they start treatment, early on treatment, and at the time of disease progression. There's different things that I want to do with this. First, I want to think about that approach. Can I personalize treatment earlier on? And for me to know that, I have to collect the samples and then analyze and find out what is the best timing for this, what is the best technology. So if you are approached by Jill Aurelio, she's the research coordinator working with me on both of these projects, is under a big umbrella of a master protocol called TCC. So I really appreciate if you can participate. So what else is the future that we're looking into? In the next slide, we're trying to partner with an institution to see if we can expand the ctDNA research for patients with small cell lung cancer. There is still a good portion of patients that we see, and this would be focused in patients that have limited stage small cell. Again, trying to get the patients in the beginning of their journey and see if we can use this to create better treatment strategies. And the same for patients with early stage non-small cell lung cancer undergoing surgery. And again, we're thinking about clinical trials, and Dr. Gray has a leadership position in a big cooperative group. So hopefully we can take this to trials in the future. And how can you help? Well, first of all, please participate. There's no way we can do this research without you. And the participation includes like blood donations when you're here for your visit. And donations, how do we use these funds? We need to pay for blood processing and storage, the research coordinator that works with us, the tubes. There's so many things that that need to be paid for to do this research. So any small donation is super helpful. And I follow what one of our senior colleagues has done with his studies, and I'm committed to sending updates when the study is published to the participants, to the family with a letter. So if you help participating, donating, I will be very grateful. So if Joe talks to you, please consider participating. And thank you so much for helping us advance the research in this space.
Really wonderful. Thank you so much, Dr. Pellini. I think, when we think about where we started off, where we've been with lung cancer for the past 10, 20 years to where we are now, this is really cutting edge, and this is how we're going to move the field forward. So we have a saying in thoracic oncology, tissue is the issue. We recognize that a lot of patients with lung cancer, their primary disease is within their thoracic cavity. Doing biopsies sometimes can be very challenging. It's just not feasible in some patients. And so that's why this is called a liquid biopsy, a blood test. I just went to my doctor's appointment today, got my blood taken, something as simple as that, and the richness within which we can learn about your tumor, learn about others' tumors, as well as helping to move the field forward. So thank you so much for that wonderful summary. All right, so we'll continue forward. And again, we'll hold all the questions to the end. We also have Dr. Sam Freyaldenhoven. He is one of our premier thoracic surgical oncologists, and he has a focus on robotic surgery. He's very dedicated to early detection and will be speaking to us about lung cancer screening and prevention. Dr. Freyaldenhoven, please take it away.
Great. Thanks for having me. Excited to talk about this issue. So lung cancer is a bad disease. It's not only prevalent, it's the third most common cancer in the United States. Over 200,000 individuals will be diagnosed each year for it, but it's also a very deadly disease. And over 120,000 people will die from it every year. In fact, it has more deaths attributed to it than the other three most prevalent cancers in the United States. The Raymond James Stadium, the stadium for the Tampa Bay Buccaneers, has a capacity last year of over 70,000. That means almost twice the number of people that die from lung cancer could fill Raymond James Stadium. Next slide, please. And that's mostly related to the stage or how advanced the cancer it is when it's diagnosed. In fact, over half of the cancers that we detect, it's already spread to other areas outside the lung and chest in this distant disease. Only about 1 in 5 patients will have localized disease where the cancer is only still within the lung tissue itself. And this really translates to overall outcomes and survival. When we can detect it early, patients do really well. The national 5-year survival is over 70%. But when we have distant disease, we have less options for treatment, and the survival is much worse for that. And so next slide, please. And so how do we do better? It's an exciting time in lung cancer care, and I feel privileged to be in the field and be a fantastic part of a team at Moffitt. But how can we do better? Unfortunately, I won't have time to talk about everything, but I'll mostly focus on early detection during this talk. You can go to the next slide. And so how do we improve the detection, detect it at an earlier stage, better treatments? Well, we need a test that can do that. And so the really components of that test, you need a reliable test, a specific test that's able to detect it with a high efficacy. It's easy to administer with minimal discomfort to patients. It doesn't cost a lot, and it's readily accessible. And really what these things translate into is improved health outcomes for people. And lastly, once we have this test, who are the patients that we screen and who would most benefit from it? Next slide, please. And so people have been looking at this for a long time. They've looked at multiple tests, including chest x-rays. It just wasn't quite as sensitive enough. It wasn't able to detect the early stage lung cancers. And so as the more CT scans became more prevalent, more focused towards those, we had more focus towards that. And so in 2011 was really a landmark trial for us, in which it showed a publication in the New England Journal that had reduced mortality with low-dose screening. And ever since then, the multiple agencies that control funding in the United States, both the U.S. Preventive Task Force, as well as the Center for Medicare and Medicaid, have approved for this and really recommended it for high-risk individuals. Next slide, please. And so the criteria for screening has changed over time, but this is the most recent criteria for screening, both from the U.S. Preventive Task Force and Medicare and Medicaid services. And so this is really important because that means insurance will pay for this for patients for no out of cost. And so those ages include people from ages 50 to 80, and then 50 to 77 for Medicaid and Medicare. patients who have smoked for 20 pack years, that means smoking a pack a day for 20 years, or that's half a pack for 40 years. And then they've quit smoking within the past 15 years, or they're still smoking. And so these are the patients that would qualify for lung cancer screening. But there's a big push to expand that population so that we can get more patients screened, detect more lung cancers, and treat them earlier. And so, in fact, the American Cancer Society this year has recommended that we remove the criteria for current smoking or quit smoking within the past 15 years. And so hopefully these task forces that really control the funding in the United States will listen and expand this criteria. For patients that don't meet this criteria, it's still relatively inexpensive. It would cost about $300 for out-of-pocket costs for those patients that either have flex spending accounts related to their health insurance. So we go to the next slide. And so what did this lung cancer screening, what's it really doing? What's the impact on patients? And so on the left, you can still see what is the national stage when patients are diagnosed. Again, the majority of them, over 50%, it's distant disease, so it's outside of the chest. And so with lung cancer screening, this is just data from one of the trials on a 10-year follow-up. These ratios are actually flipped. And so instead of the majority of them having distant disease, it's actually reversed. So the majority of them are localized disease still within the lung, in which we can still do local therapies for. And so what that's really translating into is better outcomes for patients. And so in a 10-year follow-up from these studies, women were 33% less likely and men 24% less likely to die from lung cancer in those that were screened. So you can go to the next slide. Even though we have such great benefit from this lung cancer screening, it's still really not being utilized on a local or national level. So the graph on the left is just depicting the percentage of eligible population screens. So those patients that met the criteria, what percentage of those patients are actually getting screened? And so this is comparing lung cancer screening to other more prevalent screening modalities for other cancers, including cervical cancer with pap smears, breast cancer with mammography, and colon cancer screening with colonoscopy, sigmoidoscopy, stool samples, all of which are very, very invasive, despite lung cancer being a relatively uninvasive, cheap, fast modality. Lung cancer screening is still really lagging behind. The other cancers are getting anywhere from 60 to 80% of their eligible patients screened. But still, lung cancer is only 5% of the patients who are eligible are actually getting screened. That's 1 out of 20 nationally. And the graph on the right is just looking at a state level data. And it's even worse in Florida. Only 3% of eligible Floridians are getting screened for this. They're in the bottom 11th state in the United States. And so how do we improve this? You can go to the next slide. And so we already have a great test. It's reliable. It's able to detect really small cancers that are much easier to treat. It's inexpensive. And so one of the issues is it just not accessible to patients? So you can go to the next slide. And so what are we doing at Moffitt? So we just have approval, and we have these new mobile lung screening vehicles. And so these are custom vehicles. They have a generator and a low-dose CT scanner that we can take out into the community, into a parking lot, out where it's more accessible to patients, and patients can come and get screened and detect these small lung cancers. We have a lung nodule clinic. So what do we do once we have the images? You can see one of our specialists to review the images and sort of have an expert opinion on what's going on with your nodules, what do we need to do about them, and how can we best detect these lung cancers early, improve lung cancer outcomes. Thank you.
Perfect. All right, excellent. Well, thank you very much, Dr. Freyaldenhoven. I think this has been really exciting. I think we've given you some information that goes from before, you may have a diagnosis of lung cancer, when we may be more in the prevention phase, trying to detect things early. We also want to be able to identify ways where we can track your cancer over time and help make an impact throughout your treatment course and make this something that is minimally invasive for those that we need this. we need this for. So very interesting presentations, and thank you both, really exciting information. So I think at this time, I wanted to just take a moment and introduce you to one of our partners here at Moffitt, Mark Ketterer. Mark is with the Moffitt Foundation, and he partners with our Thoracic Oncology Program. And the goal here is to ensure that we receive the research dollars we need to get clinical research off the ground and continue to make advances that impact our patients. If you would like to learn more about how you can help, if you could please contact Mark. You see the information here. And I'm just wondering, Mark, would you like to take a moment and say a few words?
Sure. Thank you very
Wonderful.
much, Dr. Gray. And I personally am very thankful for each of you here at Moffitt and being accessible to our friends and patients this evening. Philanthropic support has had a huge impact on the research happening at Moffitt, such as what Dr. Pellini had outlined earlier. And, a lot of this stems from brilliant ideas for new detection and treatments. And our physicians have a tall task to move that through bench research into FDA-approved trials and FDA approval to our patients. So by making a gift to Moffitt, you're really enhancing the timeline of these wonderful discoveries and getting them to our patients quicker. Like Dr. Gray said, please reach out to me and find out how you can contribute to our mission of preventing and curing cancer and what that gift can do to some of the research that we outlined this evening.
Perfect. That was wonderful. Really appreciate you, appreciate everybody on the call, and all of the efforts that come together to make the research that we do possible. Now, ladies and gentlemen, we would like to invite you to ask your questions. I can see that some of them have already been posted, so thank you for your engagement. And but you can write your question in the Q&A box. You can make it anonymous if you feel more comfortable. I will read the questions, and I will invite the faculty that we have on here to answer the questions as they pertain. All right. So why don't we go ahead and get this kicked off here with our Q&A. This is one of my favorite parts of this evening. So I'm going to direct one of the first questions here to Dr. Pellini. And I'm going to ask Dr. Pellini and Dr. Freyaldenhoven, why don't we go ahead and make sure everybody's camera's on so they can see you. We're here, can you measure the amount of circulating tumor DNA in the bloodstream? And, what do you use to identify the extent of cancer present? So can we quantify things, and does that quantity have an impact?
So while some technologies allow us to quantify the amount of ctDNA, that does not impact what we do in clinical practice. So this is not the use of this technology. And not every test that we order for commercial companies comes with an amount. There is a correlation between the levels and the degree of cancer spread, but that's not going to impact our clinical decisions. So that's not something we monitor.
Yeah. I think those are good points. And I think even, when the technologies first came out, right, I think a lot of us were expecting, oh, great, we could use these as a value, kind of almost like what I would equate perhaps for a PSA in prostate cancer. And we're still learning. It's new. This is why we need the research. This is why we need to support the efforts of physicians and experts in this area, like Dr. Pellini. She really is leading the charge in this area, not just at Moffitt Cancer Center, not just nationally, but really internationally. She goes around the world speaking on this topic. So you're in great hands by supporting this research. And so I think some people are interested in learning a little bit more about the CT scan and about the mobile unit. And will the CT scan, Dr. Freyaldenhoven, will this help determine whether the tumor is localized or if more testing? So if you find an abnormality on a screening CT scan, whether it's done on the mobile unit or at the center itself, what's next? What do you take it from there?
So what the CT scanner is really doing is really detecting different densities in the lung tissue. And so what will happen is you'll have this small area of increased density, and it can be there for a variety of reasons. Many people have these nodules or these small densities in the lung, and they could be benign, or they could be malignant. And so they need to do additional testing, whether it's repeat CT scans, additional studies such as a PET scan, which uses a labeled glucose molecule to see if there's any increased glucose utilization. and then it can lead to other tests to sort of investigate it more to see if this is a malignancy. So while it's able to detect these small nodules, it's able to better give us ideas about what needs to be more concerning and more investigation.
Yeah, I think those are great points. And I think one of the key things there is that you have the experts who do this and focus on this all day long. They're very familiar with looking at the scans, our radiologists, our thoracic surgeons, like Dr. Freyaldenhoven. And many times, this comes up in our thoracic tumor board, our multidisciplinary conference, where we all get together and patients are referred here for a consultation. And because of the familiarity, because of the expertise from our team, especially our thoracic surgeons, they're able to even look at scans and say, I think this is something that can be followed. I don't think you need to get to the operating room right away. Dr. Freyaldenhoven, do you want to talk about how you and your colleagues help make that determination?
So I think that lung nodules, I think a good analogy for them is sort of like, moles or freckles on your skin. We look at both the size of them, we look how they're changing, we're looking at sort of the density. You go a lot of times to your dermatologist and they look at something on your skin and say, oh, that's fine, we'll look at it again in 4, 6, 12 months. And so that's similar to what we're doing. We're assessing both the size, the change, and certain characteristics of it. And so a lot of this comes with experience, looking at a lot of scans, and both talking, as Dr. Gray said, within a group and multidisciplinary teams.
Perfect. And I do, we also have our thoracic pulmonologists that, really add to the richness of the expertise and looking at everything, right? And making sure that we're not making decisions within a vacuum. So great. I think that's a great point there I love that analogy that you just gave about freckles, moles on your skin. How are you following those? How do the dermatologists make that, make that determination? So, hi, Ed. So Mr. Cutler here how soon will the mobile lung cancer screening unit be available to the community? So I'm gonna take that one. It's a really good question. So we actually got a very generous donation to make this happen from events such as this. And we are very much engaged with reaching not just the patients that have the ability to come to us, but also maybe reaching those patients where it may not be so easy for them to come to us, and making sure they have the same access, the same access to care, but also the same access to the quality care that we deliver at Moffitt every single day. Our goal is really to have this up and running by next year. We definitely I think many of us know November is Lung Cancer Awareness Month. And so we're hoping to have it well before this by next year, and have already started working with some partnerships. So great question, and I'm so glad that Dr. Freyaldenhoven was able to highlight what we've started with the mobile unit and where we hope to go in the future. Okay, so we have a couple of questions here that I'm going to lean on Dr. Pellini. So pretty similar here. So people are asking more about the targeted therapy space, right? So what's on the horizon for EGFR? What's on, if your tumor harbors an EGFR mutation, what's on the horizon for ALK? Do you want to get us kicked off with that?
Yeah, I think for EGFR, there were a lot of exciting updates this year at ESMO, that is the European version of our huge American Society of Clinical Oncology meeting. Yeah. There were 3 studies showing very promising results for new combinations in the frontline setting for patients with EGFR mutant lung cancer. Now we have to see what is going to be approved or not, and we have more than one option really that we can discuss with patients. So I think this year was EGFR positive heavy in the meeting, so very exciting. For the ALK space, there was something very exciting in the adjuvant space that was presented here. So bringing these therapies from stage 4 to early stage to really try to not only prolong life, which is very important for over 50% of our patients, but also increase potentially cure rates for our patients that have resection. So I think these are the most exciting news in that space. I don't know if I missed anything, Dr. Gray, but...
No, I think that was a great summary. There's the EGFR question, I'm going to say I agree with you. It's a loaded question. There's so much data that has come out, and some of it is actually taking the standard of care, osimertinib, and adding chemotherapy. I definitely will be talking to my patients about it. I think it's for the right population. I think there is a subset of patients who have tumors that harbor the EGFR mutation that's a little bit more aggressive, and that we need to be more proactive. But I also think there may be a subset within there that maybe it's a little bit slower growing tumor, and we don't need the chemo upfront. These are the places where I think advances like liquid biopsy, right? Maybe something that we, can look at and help make a determination about who needs all three therapies, right? Who needs two chemotherapies and the oral therapy? Or maybe somebody has a little bit of a better prognosis tumor and can just get the oral therapy. So I think this is where everything starts. You can start to see where all these things marry together, and that having this, the platforms and having the technology and having the ability to take these deeper dives and interrogate, we're going to be able to even further personalize therapy well beyond just which mutation do you harbor? It's also now which therapy, right? Dr. Pellini, what do you think?
Yeah, and we have a trial open at Moffitt that actually uses liquid biopsy to help us make this decision.
Exactly.
So if you do
that Dr. Pellini is leading.
Exactly. Yeah. So if you do happen to have an EGFR mutant lung cancer, this is a trial that I think Dr. Gray and I agreed that we think liquid biopsies are here to stay and help us make decisions. And the only way to prove this is with research and clinical trials as well. So I think this is a beautiful trial. So.
Yeah, exactly. And I think it's a great question that was asked in the chat, because I think it helps us to highlight how we marry all of this together in the background with what is your current standard of care and how to improve upon it. Or maybe we think that you have potential to be overtreated and you should actually get less therapy. And this is where the liquid biopsies and that research is so critical. There's multiple ways to personalize therapies, not beyond, I think, just trying to match you to the best therapy. There could be length of time that you're on the medication. There could also be whether or not you need more than one medication. We also have data that has come out in the earlier stage setting, and I know we have Dr. Freyaldenhoven on here, and it's really important that we work with our thoracic surgeons early on when you have newly diagnosed early stage lung cancer. The therapies now have really also changed out of ESMO, right? So there's neoadjuvant therapy, which means you're going to get therapy prior to surgery. And then there's adjuvant therapy, which means we think that you should get the therapy after surgery. And so Dr. Freyaldenhoven, I'd love if you could expand on that. And maybe, you get a patient who comes in for a screening CT scan. You do think they have a high suspicion, high index of cancer. And now there's a biopsy and now you have cancer. How are you making that decision between who do you take directly to the operating room? Who do you think you need neoadjuvant therapy? What's the thought process behind that?
So I think whenever we do, the nice thing about lung cancer screening, we're picking up smaller tumors. And so there have been great advances in the surgical treatment in people who can have surgery. So when you have a local disease, you need a local therapy. And so those two things are either surgery or radiation therapy, and both have made large advances recently. And so patients who can tolerate surgery, so patients that don't have a lot of medical issues, they have healthy lungs in which we can remove a portion of the lung and they still be able to move and breathe without having any limitations, we would offer surgery to. And the nice thing is now that we're getting better at surgery, we can remove less of the lung. Used to, if you had a small tumor in one of the lobes, we would have to remove the whole lobe of a lung. But now we can do even smaller portions, segments of resections that people tolerate much better and recover from a lot quicker. So the average length of stay now in the hospital after a lung resection is 2 to 3 days, whereas it used to be weeks or so with a larger incision. And so in terms of, who do we decide about who needs induction therapy or neoadjuvant therapy? It really comes down to if we can make sure that we can get out the tumor safely and make sure we get it all out and it hasn't spread to the regional lymph nodes. If it's gone to the regional lymph nodes, we start to think about induction therapy beforehand to treat that and then follow up that with surgery. And so we know that patients who get a combination chemotherapy plus an immunotherapy in up to a third of those patients, when we go and do the surgery and take the tumor out, that there's a complete pathologic response. So that meaning that the whole tumor has died. There's no alive cells in the tumor. And even those that don't, so you're not in that 30% or so that get a complete response, the majority get a major response in which there's a large portion of the tumor that's responded.
Yeah, I think that's I think that's an outstanding summary. And then within that, now that we have a lot of drugs approved or look promising that they're going to get approved in this space, and we're always working to improve upon that, right? We're not satisfied with where we are with the standard of care and driving things forward to get even better outcomes for our patients. I see a really interesting question here, Dr. Freyaldenhoven. Could you spend a little time maybe talking about the difference between a low dose CT scan and a regular CT scan, and who should get which one, right?
So a CT scan is just a bunch of X-rays. So you go through, it's essentially a tube, and it spins, and it takes a bunch of X-rays of your body, and it uses a computer program to sort of reconstruct the imaging of your body. And so the difference between a low dose CT scan and a regular CT scan is just the number of X-rays. So less radiation to reconstruct sort of the anatomy that we see. And so we say low dose because we can see everything that we need to see with the less radiation exposure. Even with a low dose CT scan, the average exposure from one scan is similar to a flight crew that travels transcontinental throughout the year. So the flight crew, the flight attendants, pilots, they get exposed to the same amount of radiation on a yearly basis that you would get from a low dose CT scan. So
I think that's a good point, right? And we also have a question here about, can CT scans be harmful? What's that kind of threshold? Can too many CT scans be harmful?
Yes, it's nowhere near. So even if you get one of these a year or even multiple a year for several years, it's nowhere near where you would have side effects. You won't glow, you won't develop cancers from it. It's really a really, really low dose of it.
Yeah. And I think for those that have cancer or those that are at high risk for those criteria that Dr. Freyaldenhoven outlined, that the risk of the cancer risk is higher than the risk of doing the CT scans. And that's been studied pretty extensively. So great. Thank you for that summary. So Dr. Pellini, we have somebody here who comes to Moffitt. They've had their cancer removed on a regular basis. What do they do if they are interested in donating blood to research and becoming more involved?
Well, first of all, thank you. We appreciate the participation. So I think you can ask your physician, first of all, is there any study I can donate blood to? Because like I said, Dr. Gray and I do have a study that we have for patients that have surgically resected cancers. And the research coordinator is Bruna Pellini. Or if you just remember my name or Dr. Gray, you can say, hey, I heard Dr. Gray and Dr. Pellini have a study. Can I donate blood? They will direct you to us, and then we'll direct you to the team. So yes, we have for basically every stage at this point, almost.
Wonderful. And we'll be sure to put back up, I see that somebody's interested in getting Mark's information. We'll be sure to get that slide back up and try to put the information in the chat. I hope you guys can see the chat. So you can get his contact information. Okay, perfect. We have a couple of questions here, Dr. Pellini, on immunotherapy. What do we think that interaction is with liquid biopsies, and what do we think is on the forefront for immunotherapy? I know I was on a panel last week, and we got asked what's next, right, beyond what we have now, and I actually talked about liquid biopsies and using liquid biopsies to help with our treatment decisions. So where does immunotherapy marry with liquid biopsies? And then what's on the forefront for immunotherapy?
So for liquid biopsies, I think the idea of using that in a clinical trial context to see if we can detect which patients are responding well to therapy or not, and see if we could change treatment to something stronger. Nowadays, I wouldn't do that because there's so many barriers. We don't know which technology is better. B, insurances won't approve a changing therapy without the evidence of cancer growth, right? So to get a test that won't affect what I'm doing, I think is a waste of money. So I don't order things that won't change what I do or won't influence my decisions. In terms of new things for immunotherapy, I think vaccines combinations, we actually do have a study here with vaccine. We have like oncolytic virus studies, cellular therapy studies. We have Dr. Creelan here, who is like a world-renowned expert in cellular therapies. And I think also they're investigating like different formulations of immunotherapy, because infusion times, they take like an hour and a half or more. So what if we can give these drugs through an injection, a subcutaneous injection that will take a few minutes? So I think this is the big thing, is how can we give these drugs in a more efficient manner, if I may, so patients don't lose so much time.
Yeah, and I think that's there's a question about the oral immunotherapy. To my knowledge, I don't know that we have that just yet. Are people working toward that? Absolutely. And I think that bridge right now is really going from an intravenous infusion that takes up more time to that subcutaneous, and then building that outward, or doing something like a vaccine, right? I think I mentioned I went to my doctor today. I just got an updated tetanus vaccine. You just sit there, you get one shot, and we can, you go about your day. So I think there's so many ways that we can innovate when it comes to therapeutics for our patients. And I think we're off to a great start. Very much a long way to go. So I do see some questions on here specific to clinical trials. We will certainly get your information and get those questions over to our clinical trial team, so that we can make sure that we are getting things as connected for you as possible. I think this question is kind of a little, it's an important question. I think we do have to acknowledge this. As we have made significant advances in the field, we do also have to think about the financial implications. The question here is, why is Tagrisso so expensive? It's tier 5 on my insurance. And, I'm concerned that they're not going to approve it this coming year. Dr. Pellini, do you want to talk about what do we do about these costs of these medications? What availability, what are we doing in clinic? How are we working with our pharmacists, with our social workers?
Yeah, so it's probably about something that the company changed for patients that were accessing the drug through their foundation. So there's a way around it. It has a few steps. So basically, first of all, put the patient in connection with our social worker, because we can see if there's any foundation money, even outside Moffitt, through American Cancer Society, things like that could support copayment. If a patient shows they have gone through the steps, they haven't been able to find any grants, then I believe, based on what they said, they could consider continuing giving the drug, even if it doesn't meet the threshold. So it's extra steps, but that's something around it. So looking for grants from cancer societies, patient advocacy groups, and if that doesn't work, then show the proof I did everything, and then send to the company, and I think they will look at it. I will say there's a movement of us thoracic oncologists signing letters to send to the company as a group. So because we're not happy with that too. That's the best we can do as a group.
Yeah. No, I think the thing is that we all have to get together. We have to raise awareness of what I would call potential financial toxicity. We talk about the side effects of medication, the adverse events, that type of toxicity. I think it's at the forefront. And I will say that ASCO, I think, American Society of Clinical Oncology, at one of the meetings, their theme one year was really, every speaker was challenged with addressing financial toxicity when they gave a presentation. And I think it was one of the best meetings I've ever been to, because I learned a lot also. And I think this is something that we have to keep at the forefront of our dialogue. We have to try to keep these costs as realistic, and we have to all work together. And I think this is where Dr. Pellini was going, every day being dedicated to advocating for the importance of why you need these medications, and how are we going to help support the patients, all of our patients, in getting access to this quality care. So I appreciate, I know it might have been a hard question to ask. I really appreciate you bringing that to the forefront. And it is something that we are very dedicated to. And I can say that we work very closely with our GR team, our government relations team, to as far as advocacy, and particularly for lung cancer, as much as possible. All right, so Dr. Freyaldenhoven, two questions for you here. Could you help, I think we talked about this a little bit, but maybe expand a little bit on what induction therapy is and what the definition is of that. And then what is the difference between a CAT scan and then a CAT scan with contrast? But let's start off with the induction therapy question, Dr. Freyaldenhoven.
So there are a couple of different terms for it. Induction therapy or neoadjuvant therapy. It's the same concept, where patients will get some sort of medication, whether it be chemotherapy, immunotherapy, or so on. And then that's followed by surgery. So neo before surgery, versus adjuvant, which would mean surgery first, followed by therapy afterwards. And so those are the two sort of strategies, sort of just the order of treatments. In regards to the contrast versus non-contrasted CT, so whenever we look at CT scans, in order to see blood vessels structured a little bit more clear, we can sometimes give contrast. And all that is an injection into an IV. And it's with a solution containing iodine. It helps light up blood vessels in some tissues. It can be sometimes harmful to the kidneys in some patients. And so, but for our purposes, in terms of lung nodules, lung cancers, the vast majority of time do not need it. And so all of the CT scans are non-contrasted. So whenever you go get your low-dose CT scan for lung cancer screening, there are no IVs involved, no pokes, no shots. You just go sign the paper, lay on the table, and they slide you through.
Yeah, and I think that's a really good point. I think, we talk about screening, when we talk about screening as a whole, right? We think about things like the colonoscopy, right? There's a huge prep. You have to have somebody drive you there. You're sedated for the procedure. You basically have to take a whole day off of work just to get that done. The PSA is a simple test. Also, it's a blood test. But the CT scan, the low dose CT scan, you bring up a really good point. It's also very quick. You go in, you are on the table. The scan takes maybe a minute or two while you're on the table, and you get to go home. There's no poking or prodding. So very good points to bring up, and keeping it as simple as possible, because we understand everybody's very busy and has a lot going on, and we want to make healthcare accessible as well as with preserving that quality. So great. That was a really good point about how quick that can be. Excellent. And so Dr. Pellini, we have a question here about if we have a ROS1 gene rearrangement, what's going on within that area. And there's also here about KRAS mutation and clinical trials also.
Yeah, so for ROS1, there's some new drug. There's one that just has been approved actually last month for patients that have previously been exposed to a ROS inhibitor. It's from a different company, so that's the new drug. There's some studies also assessing combining with chemotherapy, like in patients that are higher risk. So this would be the updates. This is new approval and maybe combining with chemo. For KRAS mutant lung cancer, the space is super hot now. So we have a lot of trials, and we have a lot of trials in line to open as well. And not only for G12C, we're talking about all KRAS mutations. We're hopefully going to open the trial soon on that. So new agents, new combinations. We have one study Dr. Gray is leading in the first line setting that you can get a G12C inhibitor with immunotherapy. I have one that is for patients that already got immunotherapy, or even a inhibitor that is a new class of drug. I have another one for other KRAS mutations with immunotherapy and oral drugs. So there's a lot in that space, and we're actively opening studies for this patient population.
Yeah, exactly. And I see that somebody's suggesting that we also check out another agent, some other newer agents out there also. So we will definitely, again, get that information over to our clinical trial. We're very open to suggestions and doing anything that we can for our patients. And then we're going to try and do one more question real quick before we have to close out. My wife had stage 1 lung cancer, adenocarcinoma 4 years ago. It was surgically treated, no chemoimmunotherapy. Should she have a liquid biopsy? What do you think about liquid biopsies in early stage or in patients who don't have any evidence of cancer but may have had cancer in the past? And what would you be looking for within her tissue and her blood? What's most relevant?
Yes. So the short answer is no, I would not order anything commercially for this patient population at this time point. In a research context, we're investigating that. But if a patient came to me, I wouldn't do anything that would change what I do. Why? If I don't find any DNA from the cancer, it doesn't mean that it's not there because the technology is not good enough at this point. And if it does find, it may take months or years for the cancer to show up. So I won't do anything with a positive result as well, besides make myself anxious and the patient anxious. So my answer is I wouldn't do it outside of a research context because I won't act on it.
Yeah. And I think you're hitting the nail on the head there, right? We do have limitations with what we can detect in the blood. And I'm very similar to Dr. Pellini in how I practice. If I don't think something is going to be useful for you, if I don't think that it's going to impact my decision making, as we just had a conversation about financial toxicity, I really don't think it's appropriate to order it outside of a clinical trial where we think potentially we're contributing to the field and we're going to be able to pull the data and help maybe move the field forward, whether or not the answer is yes, we should be doing it, or even that we clarify that no, we shouldn't be doing it. So really, really great points. I think we have one more question real quick. Can you get too much contrast over time, IV contrast? Dr. Freyaldenhoven, thoughts?
Short answer, no, not IV contrast. It's usually in the short term when you get, it's mostly renal. Some people have allergies to iodine and can have allergic reactions to it, but it's mostly in the short term. But again, our scans that we're using for screening and monitoring for lung cancer do not have contrast in them.
Correct. Yeah. So I think discussing that with your doctor about what they think is the right indication for you, monitoring your renal function is critical if they do think that you need contrast. Well, I want to thank you so much for joining us today for your very thoughtful questions. I want to also thank our speakers. Thank you to Dr. Freyaldenhoven. Thank you to Dr. Pellini. If you were unable to get your questions answered tonight, as I mentioned earlier, don't worry. We will follow up with you and get answers to your questions. And I think, in the interest of time, I think that will do it for us. Thank you very much again for joining us. We all hope that you found this webinar informative, and we really appreciate your continued support as we work to revolutionize and personalize lung cancer care and provide the best possible outcomes for our patients. And have a wonderful evening.